In this video, we're going to familiarize ourselves with clinical depression. We're going to delve into what it is, its symptoms, how we can classify depressive disorders, what causes depression, and finally, how we can treat it. The depression that we're going to talk about today isn't the feelings of sadness we get when our favorite TV character dies in the show or when we're feeling a bit under the weather. It's the kind of depression which is characterized by a persistent feeling of sadness which oftentimes can affect the patient's ability to function. When I say the patient's ability to function, I mean the patient finds it difficult to maintain social interactions, underperforms in school or work, or it might even reach a point where the patient becomes catatonic and immobile. This is called clinical depression, and it is a mood disorder. Although depression is widespread, very few patients remain permanently depressed. As to who it affects, females are twice as likely to suffer from depression than males because of many reasons, the most notable being the changes in hormones during puberty, menstruation, pregnancy, and perimenopause. It's also because men and women have different coping mechanisms. While women tend to respond to stress by developing depression, men respond by engaging in drug abuse. There are many symptoms that we can notice in a patient diagnosed with depression. The most common is excessive and prolonged grief, which we would call a depressed mood. The patient might feel that everything is meaningless and hopeless, or they might feel guilt. A common misconception is that depressed people lose weight, but that's not always the case. They can also gain weight. They lack motivation and energy, which is oftentimes contagious, leading to social withdrawal. They are unable to feel pleasure in activities they once enjoyed, and they might view themselves as incompetent individuals. This leads us to something that we call the cognitive triad of depression, in which the founder of the idea, Aaron Beck, suggests that depressed patients hold negative views of themselves, the outside world, and the future. As we said, depressed patients withdraw from any social interactions. They might contemplate or even act upon thoughts of death or suicide in severe cases. They experience sleep disturbances, whether that may mean sleeping too little or sleeping too much. And finally, there is a noticeable slowing of their movement and speech, something that we refer to as psychomotor retardation. To be diagnosed with depression, the patient must experience at least 5 of the symptoms highlighted in blue, nearly every day, if not every day, and for most of the day. Note this, depression is actually one of the few disorders, alongside bipolar disorder, that requires at least 2 weeks to be diagnosed, whereas all the other disorders must persist for at least 6 months to make the diagnosis. There are many variations of depression which differ depending on the intensity, duration, and nature. Generally, we can classify depressive disorders into major depressive disorder, persistent depressive disorder, seasonal affective disorder, and postnatal depression. Note that there are many more variations, but for this video, we're only going to focus on these 2. Beginning with major depressive disorder, or clinical depression, it is severe depression that develops suddenly without any seemingly external cause and persists in bursts of episodes. When I say persists in bursts of episodes, I mean that these episodes don't last too long and they come and go, but when they occur, they are severe each time. To be diagnosed with major depressive disorder, or MDD, the symptoms of depression must last for at least 2 weeks. Now, I want to stop here for a second and focus on what is highlighted in blue. Based on what we said, MDD is severe and doesn't last long, meaning that it is not chronic. So, when we come to compare between MDD and persistent depressive disorder, we'll notice that MDD is more severe and less chronic. Alongside the typical symptoms of depression, MDD does not involve mania at all. Mania is basically the complete opposite of depression. It's hyperactivity. MDD affects the patient's ability to function, and patients are almost always suicidal. Persistent depressive disorder, previously known as dysthymic disorder or dysthymia, is a milder variant of depression that persists for a longer period of time. It involves symptoms similar to MDD, but the symptoms must last for at least 2 years in adults and at least 1 year for children and teens to be diagnosed with persistent depressive disorder, or PDD. When compared to MDD, it is less severe but more chronic. Just like MDD, PDD does not involve mania, but what's different here is that it does not affect the patient's ability to function. Here's a visual diagram to differentiate between MDD and PDD. As we can see in major depressive disorder, the patient enters an episode of severe depression, then returns to their normal state before regressing again into their depressed state. This repetitive pattern must persist for at least 2 weeks. In persistent depressive disorder, however, the patient experiences a depressed state less severe than MDD, but continues to feel depressed for at least 2 years to make the diagnosis. So, what causes depression? While there isn't a specific known cause for depression, there are many hypotheses on it. Taking this from a clinical pharmacist standpoint, we're more interested in the physiological aspect of the illness, so that's what we'll begin with. There's a theory called the monoamine deficiency theory, which states that the symptoms of depression are caused by a deficiency in certain neurotransmitters, including serotonin, dopamine, and norepinephrine. In terms of hormones, research has revealed that an increase in cortisol levels and a decrease in thyroid hormones can also contribute to depression. There's another theory which states that an individual with a predisposition to depression, whether that predisposition be genetic or influenced by another factor, will develop depression upon exposure to a significantly stressful stimulus. For example, let's suppose that we have 2 individuals, individual A and individual B. Upon being exposed to the same stressful stimulus, for example, going through a divorce, individual A develops depression due to childhood trauma, which is the predisposition here, while individual B does not develop depression due to growing up in a healthy household. Of course, life isn't always black and white, and this is only an example to deliver my point. Oftentimes, behavior plays a huge role in whether the individual develops depression or not. Patients who don't receive enough love, compassion, or appreciation from others are likely to develop depression, and their depression might worsen if they receive attention for being depressed. In terms of psychology, the psychodynamic theory by Freud and his followers states that any kind of separation from a parent or regressed anger following that loss can lead to the individual developing depression. Learned helplessness is the belief that one is helpless and cannot achieve their goals no matter what. It's brought about by being exposed to multiple negative events that the patient cannot control. For example, let's take a student who constantly fails math tests despite studying hard. They might think, no matter how much I study, I'll never be good at maths. What's the point of even trying? This ends with them developing feelings of defeat and hopelessness. Pessimistic attributional style is when the patient constantly blames themselves for anything negative that happens in their life. Returning to the same example with the student who fails their math tests, they might genuinely believe that because they're not smart enough, that means they will fail at anything else they do in their life. Because they interpret any failure as being their own fault, the feelings of hopelessness and lack of control can spiral into depression. Finally, ruminative response involves constantly dwelling on negative feelings, events, or experiences and focusing on feelings of distress rather than actively seeking a solution for the problem. For example, when they go over an argument they had with a friend earlier in the day, they might think to themselves something like, "Why did I say that? I always mess up. What if they want to be friends with me after this? God, this always happens to me," instead of solving the situation at hand. So how can we go about treating depression? As clinical pharmacists, we're more interested in physiological treatment, which in this case is getting the patient on antidepressants such as Prozac. In terms of psychologists, psychoanalysis would help the patient resolve their feelings of separation or anger, and cognitive behavioral therapy helps the patient recognize negative, self-depleting thoughts and replace them with realistic interpretations. If all these fail, including giving antidepressants, we have no choice but to retreat to electroconvulsive therapy, which is used when the patient has attempted suicide, has severe psychomotor retardation, or enters catatonia. And that will be all for this video.